It impacts 1 in 10 women. So you either have definitely taken care of someone with this or you know someone with this. So in your career, you will be caring for someone with PCOS. And we all know that it is generally characterized by irregular periods, signs of hyperandrogenism, so just pictures of that here. So hirsutism, excess facial or body hair, severe cystic acne, and then these quote unquote polycystic ovaries. I put this in quotes because we will discuss why these are not truly cysts. And I actually sit on a panel to discuss new name changes for this disorder, so that's coming. But besides these really common symptoms, we see that PCOS impacts a whole host of issues within a patient. So we see infertility, mood disorders, cancer, obesity, dyslipidemia, so all sorts of metabolic sequelae, type 2 diabetes, and cardiovascular disease. So this is not just in a, solely limited to reproductive age times, but really across a lifespan. And this really has a huge burden on our healthcare system. So this was published 5 years ago and updated from 5 years prior. So these numbers keep going up. The total cost of evaluating and providing care to reproductive age women with PCOS in the US is upwards of $8 billion. And this goes in terms of initial evaluation, treatment of all of the reproductive disorders, all of the pregnancy comorbidities, the hypertension, the GDM, the preeclampsia, and of course, these long-term comorbidities. So this puts a huge burden on our healthcare system as well. So this is going to be really fun. And I'm going to, I don't even see if Irene's here right now, but here she is. Created the most amazing graphic for our paper that herself, myself, and Dr. Bizarski has put out for a review paper in JCI, huge deal, but isn't it beautiful? She made this, so I just want to give her a huge shout. Share with you how PCOS actually works and creates all these issues. So it happens on multiple levels. So I put a circle there, that's a hypothalamus, anterior pituitary. So we think that there's this dysregulated release of the GnRH hormone. So there used to be an LH to FSH dysregulated ratio. We don't use that as part of diagnostic criteria anymore, but we do think it contributes to the overall pathophysiology. This dysregulation of the release of these hormones can cause high release of androgens from the theca cells from the ovary, okay? And then it can also impact the liver. So when you have high release of androgens, it lowers the sex hormone binding globulin released by the liver. So that leads to, again, more free androgens and is also part of the liver. Here's the pancreas here. And these free androgens, these testosterone levels also impact the pancreas, which drives the hyperinsulin piece, which we think about as the cause of these metabolic disorders. And finally, all of this leads to this anovulation PCO morphology piece in the actual ovary itself. But this graphic is just really lovely. I had to steal it for this presentation. So as a summary, it happens on multiple levels. So at the ovarian level, you have increased androgen production, which leads to chronic anovulation. So that's what leads to these irregular periods and even this appearance of the polycystic ovary morphology on ultrasound. You have insulin resistance or hyperinsulinemia, again, driven a lot by the pancreas. And this can also lead to increased androgen production from the ovaries, decreases that sex hormone binding globulin from the liver to, again, increase these free androgens. It's also at the level of neuroendocrine, so the hypothalamus pituitary. These increased LH pulse frequencies and amplitude can cause deregulated androgen secretion. And then this is what we're going to drive into next. So what is the role of genetics, epigenetics, and of course the environment? So the contribution of obesity itself on the picture of PCOS. So we do think there is a genetic basis of PCOS. And all of my PCOS patients are like, where did this come from? How did I get this? And that's still a huge question mark. We don't really totally understand. We do know that it runs in families. So we see this in twin studies. There is a 71% correlation when you look at this in monodyed twins. But in these huge genome-wide association studies, so they're looking at huge populations and looking of PCOS patients, they're looking for any kind of loci, these genetic loci that might indicate, higher prevalence of PCOS in certain populations. And they have seen some susceptible loci in certain population in the Han Chinese and some European cohorts. Again, these are limited. I think that in terms of studies of different races and ethnicities of women with PCOS, we are lacking in this data. But we do know there is some genetic basis. However, it only accounts for less than 10% of this PCOS heritability. So there's something else must be going on. So We think there probably is some sort of epigenetic variation that leads to modification of the actual genes that can show PCOS in different forms of phenotypes. And of course, environmental factors play a huge role, socioeconomic. And what I find really interesting, so there is this intergenerational effect of PCOS. So that kind of speaks to this epigenetic role of how this passes on. So we do know that women with PCOS have children, right? Have sequelae that are related to PCOS. So there is some sort of generational impact of having PCOS yourself that you can translate to your children. So if you have a daughter, the daughter of women with PCOS have increased risk for PCOS themselves, a fivefold risk. They have accelerated pubertal development, earlier adrenarche. They are increased risk for obesity, metabolic issues, increased risk for mood disorders. And even the sons of women with PCOS have impact as well. So we see increased risk of childhood obesity, metabolic derangements, and also these boys or men eventually have increased risk for cardiovascular disease. So I love this picture. It's very busy, but I'm going to show you what this means. So I took this from Dr. Jumezik. He's at UCLA, also a PCOS expert. He created this kind of hypothetical forward feedback loop for how this might be happening from women with PCOS to their children. So generally speaking, the middle pink triangle is your placenta, right? Maternal side, fetal side. And usually the placenta has aromatase that's the enzyme that converts your androgens to your estrogens, right? REI fellows. In women with PCOS, we think that there is an issue. So this enzyme should kind of block any exposure of your fetus to any high levels of androgens. But perhaps there could be an impaired function of this placenta, or there's just such high levels of androgens in these mothers with PCOS that it does have this impaired negative feedback of the hypothalamus in the actual female fetus itself. And so this can lead to hyperinsulinemia, alter adipose function in these female fetuses, and then leading to a PCOS phenotype in girls born to women with PCOS. So it happens even at the uterus level, which I find absolutely very fascinating. And so when you think about epigenetics, you have to think about microRNAs. So just as a review, these are small, non-coding, single-stranded regulatory RNA molecules that basically impact gene transcription through post-transcriptional effects. So there have been many, many thousands that have been identified. But what's really interesting about them is they have multiple targets. So they can activate some genes, inhibit some genes. So they can really, even one microRNA can have different impact on different levels of genes. So I'm going to share with you some work that we've done with the Pizarska lab. This is the first time I stepped into a lab as an attending. So this is really fun. But what we were exploring was, we're going to talk a lot about this later, but we sometimes think about PCOS in phenotypes. So what that means is not all PCOS looks the same. Some women have high androgens, some women have irregular periods, some women have PCO morphology, or some combination. The two that are fairly disparate from each other are phenotype A, which is the complete version. You have all three things: hyperandrogenism, oligoanovulation, PCO morphology, all the way through to phenotype D, which we think is kind of the most mild, so non-hyperandrogenic. So they don't have the hyperandrogen symptoms, they don't have the hair, the acne. They have kind of this oligoanovulation piece and also the PCO morphology. So these on the spectrum are fairly dissimilar. So what we wanted to look at was to look at whether or not there are different circulating microRNAs in these women with these two extreme PCOS phenotypes. So we took 15 women with PCOS phenotype A versus 15 women with PCOS phenotype D. And what we did find, and this is really cool, was that and this is what we call a principal component analysis. So they kind of look at how these microRNAs separate, right? So you can kind of see they cluster in two different forms. And I love this one even more. This is a volcano plot. It really does look like one. So you can see that certain microRNAs are upregulated in D versus A. So this, to me, is a clue that not all PCOS is the same. There's something at an epigenetic level that is impacting the expression of PCOS. And you don't have to look at this list, but this is just to show that there are 820 microRNAs that are significantly different. And I'm just showing you the ones that are upregulated in A. So there is definitely a signal here. And so to get to another hypothesis in PCOS, there's this thought that perhaps PCOS is caused by chronic inflammation. And what we have seen in the studies are that there are elevated levels of different inflammatory markers, so CRP, TNF-alpha, IL-6 compared to non-PCOS controls. But, as I said, a lot of women with PCOS have high BMIs. So this definitely adds a bit of noise to it, because could the obesity itself be causing some of this high inflammation? So is it the obesity or is it PCOS? And also, we see race ethnicity differences. And so some of these inflammatory markers tend to be higher in Black populations compared with white. So this is a study that I just published with one of our collaborators at UC Irvine in JCEM. This is hot off the press. And what we found was, and what we wanted to look at was multiracial cytokine profiling. So we wanted to understand, in different race women, BMI matched controls, is there actually a different inflammatory profile? So what we did was we looked at 40 reproductive age BMI match, and I underlined this because this is something that hasn't been done, in 20 women with PCOS versus controls, and we looked at over almost 100 circulating immune markers and CRP. So this is just one of our graphs. I'm not going to show you all 96, but this just goes to show, so the purple, I don't know if you guys can see, are the controls, and the green are the PCOS, and you can see that it's also squares versus circles, but essentially what this showed was that PCOS showed, and this was very surprising, lower levels of immune factors. So this completely goes against what our kind of thought process is in terms of how PCOS shows itself. And so you can see kind of how the purple lines are those are the controls, are generally higher than the PCOS lines, the greens. So this was very surprising. And so what we are considering now is that perhaps this is an immune dysregulation piece. So perhaps it's immune suppression, impaired angiogenic signaling, especially in our non-obese patients. So perhaps the androgens themselves, the women with PCOS who have high androgens, that's actually showing immunosuppression as opposed to some sort of chronic inflammation piece. And the only two cytokines I listed them there that differed by race were IL-18 and one called CXCL16. And so what this showed us was that this perhaps is disease specific rather than race. And so again, thinking about paradigm shifts. So, I'm going to end my kind of like pathophysiology. There's just a lot to learn about PCOS, and you can see how it's very different in women, and I'm very driven to understand why that is. We're going to shift gears and talk about diagnosis and evaluation, because even this can be very confusing. I stole this slide from Dr. Wang like 10 years ago, but I'm still use it because I like it. So there are several criteria that are shared amongst our community about how you actually diagnose PCOS. And this is a huge controversial topic. Experts are arguing about this all the time. There's the NIH diagnosis, which needs oligoanovulation and androgen excess. Rotterdam, which I'm sure all of you are familiar with and we'll dive into more, is probably the most commonly used. Oligoanovulation, androgen excess, polycystic ovaries, you need two of those. And then finally, androgen excess PCOS society. So androgen excess is in their name, so they really care about this androgen excess piece. So you have to have androgen excess to meet this criteria. And you can see that the prevalence of PCOS can differ based on which criteria we use. Generally, in the community, we use Rotterdam, and I'm going to talk about the updated Rotterdam essentially, because it captures the most patients, right? There's more flexibility in the diagnosis. And finally, I've shared with you as well. Dr. Aziz, one of my collaborators, huge name in PCOS, really wants us to move towards a phenotype approach. So really thinking about it in terms of androgenic versus not, and classifying this way. So just to show that there's a lot of controversy in this, and really not one size fits all approach to this process. What we do know, and this is how I will champion the phenotype approach, is that we do see some differences in women who have hyperandrogenism, the classic, versus not. And we do see that the women who have hyperandrogenism, so the ones who either have, the symptoms of hyperandrogenism or the biochemical markers, have a more pronounced metabolic dysfunction. They have higher rates of insulin resistance, higher rates of metabolic syndrome, and they have the highest AMH levels, whereas the folks who are non-hyperandrogenic have a more mild profile, more mild endocrine and metabolic dysfunction. So let's talk about your workup. So you should take a very good menstrual history. As part of the PCOS diagnosis, it's oligo or anovulation. So this shows up as persistent amenorrhea or oligomenorrhea. And I use this fewer than 8 cycles per year to kind of get to that. Because oftentimes when you take these menstrual histories, patients aren't really tracking, especially when they have PCOS and they have very rare cycles. Can be excessive bleeding for some. These hyperandrogen symptoms can show up as hirsutism, again, excessive facial body hair, treatment-resistant acne, and androgenic alopecia, or what's called male pattern hair loss. So this is the modified Fairman-Galway score. So this is a visual. I used to do this when we used to see patients in person, but we would give them a paper and have them actually circle how much hair growth they would have. And I would have patients tell me, okay, if you didn't do anything to your hair, depilatate, exfoliate, or extract, laser, whatever, what would your hair growth look like in a month, 1 to 3 months? But as you can see, this can really vary from race, ethnicity. So supposedly a score of 4 can be abnormal in adults. You literally need to click 1 on 4 of these markers and be hirsute. So, I take this with a grain of salt. I think this gets to sort of the burden of hair. I think this is a really useful tool oftentimes in research, but really to get to the burden of hair growth in these patients, you want to understand how often are you having to treat your hair? How often do you have to laser? Are you shaving every day? So this is helpful to at least kind of quantify, but I think really understanding the patient experience is even more important. And the Ludwig scale is the one that we use for androgenic alopecia. So it's a little bit different than kind of general, like postpartum hair loss, et cetera. It really has, you see a thinning at the crown, and it can be scored from kind of 1 all the way to 3. There's oftentimes this kind of widow's peak appearance of the hair, and this is a very distressful symptom of PCOS, and it actually is very, very treatment resistant. Even birth control pills, spironolactone, really very difficult to treat. So I oftentimes have to turn to dermatology colleagues to help with this. And in terms of your physical exam, just to not forget when oftentimes we're OB-GYNs, we don't do all of the, metabolic screens too, but a very basic blood pressure, BMI, waist circumference, really helpful for metabolic syndrome. Look at the back of their neck. This picture up on the top right is acanthosis nigricans, this kind of velvety brown area in the back of the neck, which can signal insulin resistance. And then, of course, the ultrasound. So classically, we used to think of PCO morphology as a string of pearls. That's sort of the picture up there, but it can really just be a huge collection of egg follicles as well. In our current diagnostic criteria, we want to look for an ovarian volume of greater than 10 milliliters on either ovary. And I always teach my fellows the way you calculate an ovarian volume is it's the volume of an ellipse. So length times width times height times 0.5. So even if your machine doesn't do it, you can do it yourself with your calculator, or you can do mental math, as I'm trying to teach my kids. And the old follicle count was 12 on either ovary, but because ultrasound technology is so excellent now, that number has moved up to 20. So it's any of these. And I often tell this to patients, they're not cysts. I mean, I have a lot of patients who come to me with polycystic, consultation, and they just get frequent recurrent cysts that rupture in the ER. That's not polycystic ovary morphology. These cysts are generally trapped egg follicles. They're just a huge collection of them trapped in the ovary, right? So it's a different pathology. So I think that changing the name might be helpful for that. And then for your initial workup, there is blood work. So a lot of the blood work that we do doesn't necessarily establish PCOS, but it helps us exclude things that PCOS can sometimes mimic, right? So in order to have the diagnosis of PCOS, you can either have symptoms of hyperandrogenism or elevated levels of male hormones. So those are testosterone and DHEAS. Our lab here at Cedars is pretty good. You can order both total and free, and I think it's pretty sensitive. They use the right assay. But what you're really looking at is to exclude an androgen-secreting tumor. So if you see a super high testosterone level over 200, that's probably not PCOS. There's probably an ovarian androgen-secreting tumor. DHEAS is to rule out an adrenal tumor, right? So if you have a super high DHEAS level, depending on your lab, over 700, that would warrant adrenal imaging. So you don't necessarily need these two numbers to be elevated to meet the criteria for PCOS, but you want to rule out other stuff that could show up like that. And then, of course, ruling out other hormonal disorders, TSH. You want to rule out hypothyroidism, hyperthyroidism that could cause irregular cycles. Hyperprolactinemia can also cause irregular cycles, so you want to make sure you're checking TSH and prolactin. A 17-OH progesterone. What are we ruling out there, guys? Residents. CAH, I heard it. So again, these are rule outs, right? So PCOS, you must exclude the other diagnoses that can look like it. And once you've made the diagnosis, and if I'm pretty confident that the patient has PCOS, I will send them for their metabolic screen right up front, because you want to catch these women early. This is a lifetime disorder. If you can catch them in their 20s before they've developed type 2 diabetes, you want to do that. So I do send them for a 2-hour glucose tolerance test with insulin. Again, there's no really good clinically validated way to test for insulin resistance. So we do use some surrogate markers, but I do think this is helpful to get a sense. And then fasting lipids, of course, because these patients are at higher risk for dyslipidemia. So again, 2003 was when Rotterdam criteria came out. These are the parameters that they use. You need 2 out of the 3 of those very classic symptoms. Those are the old kind of ovary measurements. But now, as of 2023, so this is the most recent, so this is what you should stick in your head. It was published in multiple publications. This was a huge international expert-guided panel with REIs, med endo, peds endo, nutritionists, OBGYNs to come up with the guidelines. But essentially, it was the same thing, minus, they said now, the PCO morphology can include an antral follicle count of greater than 20 on either ovary, and now, and this is the new thing, an elevated AMH, quote unquote. However, they don't tell you what this elevated AMH is, because obviously every lab is different. So I will share with you my number. Based on this study, an AMH of greater than 4.7 has almost an 80% specificity and sensitivity to diagnose PCOS. So in my mind, I use 4.7. Again, this is not set in stone. This was not designed by the expert guidance panel. And we do know this AMH level. So AMH, as you all know, is a hormone released by all of the resting eggs in the ovaries. We all obsess over this, especially when we're talking about fertility preservation. But it also is very helpful in diagnosing PCOS potentially because it strongly correlates with antral follicle count. So here in 2023, alternatively, AMH can now be used instead of an ultrasound. So AMH is not necessary for a PCOS diagnosis. It should not be used as a single test. You should not use it in adolescence. And again, no specific cutoffs were provided. But what this helps with is, again, individuals who can't undergo transvaginal ultrasound, I think an AMH would be really, really helpful. So I do suggest that anyone who kind of sees a patient with PCOS, suspects PCOS, order an AMH. And why this all matters is that, we still see, even though this is very common, huge delays in diagnosis for these patients. So this was published 2017 with one of my mentors at Penn, and they surveyed over almost 1,400 women with PCOS, and 34% of them, it took over 2 years before they reached a diagnosis. Almost 50% of them saw over 3 health professionals, and obviously very low satisfaction with the care that they're receiving. So, hopefully from this talk, you now think when you see these things, maybe this is PCOS, and let's walk down the path of diagnosis, because I think it really impacts the care that we provide these women. And this was a paper I published right when I got here with Dr. Aziz, but you can an easy low-cost screening tool you can use just takes 3 questions. And this has almost 80% all the things: negative predictive value, positive predictive value, sensitivity, specificity for diagnosing PCOS. So one question: do you have infrequent or regular cycles, either more than 34 days, beginning one period to the next, or 8 or less cycles per year? Do you have male-like hair growth on your upper lip, chin, chest, abdomen, buttocks, or back? And this was just to make sure that obviously they're not on hormonal medications that might impact these symptoms. But these 3 questions alone, if they answer yes to, have a really, really good sensitivity for detecting. So this should hopefully give you some questions to ask people to kind of get you to the diagnosis. We're going to spend just a couple minutes on special groups with PCOS, because I get a lot of questions about these individuals as well. So the adolescents, our perimenopausal patients, and of course, different folks with race ethnicities who experience PCOS. So we know that in adolescence, this is a huge diagnostic dilemma, right? So a lot of the things I've described are classic symptoms of adolescence: irregular periods, acne, all the things, right? So I do see a lot of teenagers whose moms are like, does my daughter have PCOS? And so there is oligoanovulation in the adolescent that is very normal. So about 85% of cycles in the first year after menarche, your first period, are anovulatory. But this should really drop off as a girl ages into her gynecologic maturity. So by the 6th year after menarche, about only a quarter of girls should have anovulation. And there is this misconception that any degree of irregularity is acceptable. And so I oftentimes see patients who have had irregular cycles ever since menarche, and they're like, oh, well, they just kind of wrote it off to being a teenager. Be mindful of this, of course. Some level is abnormal, but most people should have a regular cycle by their 5th or 6th year after their period starts. And I like this graph because it basically shows sort of the probability that someone with that has kind of symptomatic high androgens are more likely to persist and have abnormal cycles as they get older. So the bottom line of the graph is years from menarche, so from 0 all the way to 10. And then the y-axis is the percent of girls who are still having abnormal cycles. And you can see that, everyone in the middle is that broad line in the middle. As you get out of your initial years of menarche, your cycles become less and less abnormal. But the folks that are hyperandrogenic, so that top line, are more likely to remain and have abnormal cycles. So that should be a symptom. And we mentioned, acne is very common in adolescence. So what exactly is normal versus not? When we use these modified Fairman-Gallwey scores, these are all normalized for adult women. So nobody's looking at a bunch of teenagers and seeing how much hair growth there is. So we have no cut points for those individuals. And then when you're looking at biochemical, so the levels of testosterone, DHEAS, we don't have normative data for what's actually a normal testosterone, normal DHEAS in all teenage girls. Most girls are not getting their bloods drawn. So a lot of these laboratory measurements are limited. But when we think about acne, so what's normal versus not, so moderate to severe acne through the perimenarchal years can be suggestive of hyperandrogenemia. And you should test for hyperandrogenemia, so blood work, if this moderate severe inflammatory acne vulgaris is very persistent and poorly responsive to topical therapy. And just to give you an idea of non-inflammatory versus inflammatory acne, so these are the two different types. The one on the left, non-inflammatory, you kind of see the blackheads, et cetera, but you don't have this kind of painful pustular appearance that you see on the right. So again, some level of acne is normal in teenagers, but if it's treatment resistant, if it looks like this, again, may be worthwhile checking some labs. And of course, polycystic ovaries. So Rotterdam criteria are not validated in adolescence. Transvaginal ultrasound may not be possible. When you do a transabdominal route, the follicle count may be unreliable. And 40% of adolescents have quote unquote polycystic ovaries because these girls are in their reproductive prime, right? They have tons of egg follicles. So you really cannot use ultrasound to diagnose PCOS in adolescents. And just to kind of share what the Pediatric Endocrine Society says, so this is their most recent statement, really you only need those two criteria. So abnormal uterine bleeding for 1 to 2 years beyond menarche, evidence of hyperandrogenism, so persistent testosterone elevation above adult norms, moderate to severe hirsutism, moderate severe inflammatory acne vulgaris, and minimalist approach is 99% specific for PCOS in young women. So they really, really don't suggest doing an ultrasound. However, I would say, it's PCOS light in adolescence. Most of my adolescents will tend to develop PCOS eventually, right? So continued menstrual abnormality in a hyperandrogenic teenager for a year prognosticates 50% risk of persistence. So about half of these girls resolve, the rest of them tend to have it persistent. And so what I usually do is when, I usually see them in high school, we'll do the full PCOS evaluation minus, the ultrasound, but I will bring them back in gynecologic maturity. So what does that mean? It's not even 18, it's 20, 21, 22. So truly they'll come back from college for a winter break and we'll recheck their labs off of birth control pills to really kind of, finalize this diagnosis because you really cannot give full diagnosis of adult PCOS in an adolescent girl. And now to our perimenopause, so the other end of the spectrum. So the natural history is poorly studied, but symptoms overall in perimenopausal, menopausal PCOS patients do improve. And we think that this is likely due to the lowered serum testosterone as you age as well. And serum testosterone actually decreases by 50% between 20 to 40. And as you get older than that, even more. And all of those markers, ovarian size, follicle count, AMH, all decrease with age. So sometimes I will have a consultation of a 55, 60-year-old woman for a new diagnosis of PCOS. It is very unlikely for a woman to develop PCOS in the perimenopause, menopause, if she did not have symptoms earlier. But that being said, I do like to think about women who do have PCOS established and what actually happens to them in their later menopausal years. I'm thinking about that myself as well. But you have the patients who are diagnosed with PCOS in their premenopausal years, they undergo menopause, but the folks who end up having kind of the worst symptoms, I don't even know if you can see this, nope. Here, maybe I'll try this laser pointer. You can see that the women who had obesity with PCOS going into menopause have most of these the worsened metabolic symptoms compared to those who are not obese. So the women who are not obese still may have some hirsutism, some testosterone elevation, lower HDL, but it's really the women with obesity that have the worst outcomes in menopause. So those symptoms persist. So it's definitely something to think about as these women age as well. And then finally, to think about in another special group, like how does PCOS express differently in different races and ethnicity? There's a picture of Catherine Van Heijs, one of your former residents, one of our fellows who's REI now, who published with us this review article on the racial and ethnic disparities in PCOS. And so this is I like this graph, but it's very small. You can go read the paper, but basically what she did was she kind of broke out all of the different metabolic complications of women with PCOS and showed us sort of how it differs in Black versus white versus Asian versus Hispanic women. And what she was able to determine from looking at all these different studies was that Black patients may be at elevated risk for hypertension. For insulin resistance, we see that Black, Hispanic, Asian women may be at elevated risk. Dyslipidemia, no elevated risk between the groups. And then for psychologic outcomes, Black and Hispanic women may be at elevated risk. And again, there are lots of major limitations about prior studies, race as a construct, broad generalizations of ethnicity. So it's really actually hard to study this. And we also have to consider cultural and social practices. There are many, cultures of silence. I lived in one of them myself, where women don't really talk about what happens to themselves, like with their periods, with fertility, with menopause. Different groups of women have different health-seeking behaviors, and the impact that these issues have on quality of life differs. So thinking about the geographic location, ethnic origin, cultural, social practices are also likely contributors to how PCOS manifests. And, we think about this a lot, but environmental toxins are disrupting reproductive health. So how does this play into PCOS? Obesity can exacerbate the PCOS phenotype itself. And then when we look at socioeconomic status, adverse health behaviors, geographic disparities, exposure to toxins, we can oftentimes see that patients experiencing low SES, socioeconomic status, education, are more likely to exhibit certain versions of PCOS. So here's my shout out to my fellow also in the room, Ali Kostaraka. She just presented this paper. She won a huge grant from ASRM to look at disparities in PCOS. So she really wanted to focus on Hispanic PCOS. And this really utilized that biorepository that we have here at Cedar, so a fantastic resource for research. We had about 532 women with PCOS that we basically divided into either white non-Hispanic women versus Hispanic women. And we had all of this demographic information on them, including zip code. So this is a really fascinating way of looking at SES. So you should talk to Ali if you're ever interested in using zip code data to assess SES, because all we had was their zip code and we were able to get all this information, but we wanted to understand Hispanic versus non-Hispanic white women. What was their difference in some of their anthropometrics, their metabolic markers, androgen levels, HOMA-IR, which is a measure of insulin resistance that we use, metabolic syndrome. And the way that she was able to calculate this SES score was essentially taking the zip code, and what we were able to determine from the zip code was level of income, crowding, education. So all these different measures, again, not perfect, right? Because you're not actually asking the person what these levels of information are, but on broad strokes, I think this is a really interesting way to look at it. But what we were able to see first off is, the non-Hispanics are on the left side, the Hispanics on the right, slightly older. The Hispanic women had a higher BMI, so I'm just showing you some of the statistically significant stuff. Higher waist-hip ratio, so this is a waist circumference kind of marker. They were more likely to have symptoms of hirsutism. And then they also had elevated blood pressure markers. So we know from a metabolic standpoint, the Hispanic women are doing worse. And also on these 2-hour glucose tolerance tests, we're seeing that all of these markers are different between the groups. So they have worsened levels of glucose and insulin at all the testing markers. They have elevated HOMA-IR score. So Hispanic women have worsened metabolic markers. This is not new news. We kind of understand that, right? But what we wanted to know was why. Is it because of their socioeconomic status? Is it because they are Hispanic? These are all PCOS women, so that should be the common denominator. But again, what we were able to see was, and not surprising, the Hispanic women had lower SES markers. So in terms of household income, percent of people completing at least 4 years of education, median household. So all of these SES markers were overall lower. And let's see, where are we at? And what was interesting was we wanted to see if BMI was the driver. So of course, after we adjusted all of these factors for BMI, all of it fell out. So not surprisingly, BMI is the driver of all of these metabolic outcomes. But what was really interesting was in our white Hispanic patients, when you're looking at BMI versus SES, we see that there is a negative linear relationship between BMI and SES. So the higher your BMI, the worse your SES scores are in the non-Hispanic women. But the same was not true for our Hispanic women. So there was no relationship there. So what we concluded from this was, white Hispanic patients with PCOS exhibit greater insulin resistance compared to our non-Hispanic patients, but there was no difference after you adjust for BMI. And we see that the SES scores are negatively correlated with BMI in our non-Hispanic patients, but not in our Hispanic patients. So is there some additional factor other than SES that's predisposing our Hispanic PCOS patients for these worsened outcomes? And that's the next phase of her study, which is where we're going to look at some of our inflammatory markers. Is there something genetic that's actually underlying this rather than purely the SES? Okay. All right, we're going to spend our last time points on treatment. Okay, so when we really want to target the symptoms that are impacting these patients specifically. So we're going to target menstrual abnormalities, androgen symptoms, infertility, and of course, our cardiovascular diabetes risk. So women with PCOS who have menstrual abnormalities are at a higher risk for endometrial hyperplasia. They're an 8-fold increased risk for endometrial cancer. Okay, so this cannot be ignored. And the greater the menstrual irregularity, the more severe the PCOS phenotype, generally. I usually use a marker of, if you're not having a cycle every 3 months, something needs to be done about this period. You need to withdraw it. We need to put you on something hormonal because you need to protect the lining of your uterus. The uterus does need progestin exposure. This can be done either through combined hormonal contraception, which is great because it will also hopefully help with some of the hyperandrogen symptoms. For folks who cannot take estrogen, that you can use progestin monotherapy. You can use it cyclically to bring on a cycle. And of course, the lovely progestin-only IUD is fantastic for this as well. I also stole this from Dr. Wang many years ago, but why does the birth control pill work for this? So of course, the pill allows for withdrawal bleed every month, but it also helps with lowering your androgen symptoms. And the way that it does that is by lowering your LH pulsatility, so you're lowering your testosterone production, you're increasing your sex hormone binding globulin, so you're overall just lowering your free testosterone level. So that's why, I sometimes use this to describe to patients why a birth control pill can be very helpful. I feel like I have a lot of birth control resistant patients, but if you go through the pathophysiology with them, it helps them to understand why it actually helps PCOS. It's not a mask. It can actually help with lowering your testosterone levels. So I think this is helpful. There are no so I get the question, which pill do you use for PCOS? There are no head-to-head trials comparing different types of birth control pills in PCOS as to which ones are the most effective. We don't think that birth control pills change metabolic risk. So generally speaking, I use my favorite 35 microgram orthocycline as a start if they've never tried one before. And there really should be no difference in effectiveness or risk in the various types of progestins when you use it in combination with 20 to 35 microgram dose of ethinyl estradiol. And to address the androgen excess piece, your hirsutism. So this is present in about 65 to 75% of women with PCOS. Again, we're not really sure what the abnormal cutoff is, but you should recognize that this can be particularly stressful, even if they don't correlate with what you're seeing in the office. Because like I said, these women are dealing with this hair on a daily basis, often twice a day. So really kind of you looking may not even really get to what they're really experiencing. Again, combined hormonal contraception, very, very effective for this. You can also recommend laser therapy. There's topical eflornithine. This is very expensive. I've never had it covered by insurance. And as soon as you stop using it, the hair grows right back. So I love a combination of, kind of targeting it hormonally with a birth control pill, adding on a local therapy like a laser therapy. Actually, in fellowship, we got a laser machine in our REI office to learn how to do this because it's so effective. Again, this is not covered by insurance. Oftentimes women need to go multiple times to have laser work. And usually the patients who benefit the most are the ones who have kind of more fair complexion with dark hair because the laser really targets the follicle better. But I would still recommend it. And then of course your anti-androgens, so spironolactone, anti-androgen, you can prescribe up to 200 milligrams per day. Can have pretty significant side effects like spotting, fatigue, orthostasis. It was a blood pressure medication. And you do need to recommend a contraceptive with this medication because if this person were to get pregnant, for example, with a male fetus, you're giving them an anti-androgen can cause, feminization of the male fetus if you are not on contraceptive. So I will oftentimes see a lot of derm colleagues prescribe this without a contraceptive or not have a conversation. So I just try to make a plug. And again, acne, combined hormonal contraception, again, lowering your free testosterone can help. Spironolactone can help. Topical, things like retinols can be really helpful. So again, rely on dermatology consultation for the more resistant cases. And then infertility, of course, our favorite topic. So the risk of infertility is somewhat unknown in the absence of anovulation. So there are women with PCOS who do have cycles, but we do see that about 50% of PCOS patients present with primary infertility, 25% with secondary. And, we always talk about this, especially in our patients with obesity, lifestyle modification, kind of lowering your body weight by 5 to 10% can help with resumption of ovulation. But of course, we have all of the tools in our fertility toolkit to help us as well. So we're going to go into those quickly. So prior, we used to use a lot of Clomid to treat anovulation in PCOS. Now we have moved, actually now it's been over 10 years, so really everyone should be using letrozole, first-line treatment for anovulation for PCOS. This is an aromatase inhibitor and has been shown to be superior to clomiphene citrate for ovulation induction, primarily because of this major study. So obviously all of my REI fellows should know this by heart, but you have higher rates of live birth rate and ovulation with letrozole compared to clomiphene. And they did not see any differences in any of the adverse side effects. So congenital anomalies, pregnancy loss, twin pregnancy, et cetera. This just goes to show, the red line is letrozole versus Clomid, and you can see letrozole does much better, especially in our kind of higher BMI population. So this was the whole group. This is our higher BMI, so you can see the significance grow more wide. You can use gonadotropin injections for PCOS as well. This is a treatment that is less out of favor, but I have been approached by a company that is trying to bring this back, doing transvaginal ovarian drilling. So this is a laparoscopic image, obviously, but what you do is you basically burn a couple of holes in the stroma of the ovary, and the thought is to lower the androgens to be able to hopefully help these patients resume menses and maybe proceed with fertility without needing fertility treatment. And so we see restoration of ovulatory cycles in about 80%. Actually, Dr. Wright and I did one once here. So it has happened, but because of the advent of all of our fertility treatments, this is less popular, but depending on coverage for fertility treatment, this can certainly be an option. Yes.
Is there something you're targeting when you're choosing where to burn, or is it just?
It's just kind of like spread out evenly throughout the ovary. You do about 6 to 8 punctures. Exactly. In a PCOS patient. Only. Oh my gosh. Everyone else no. Protect the cortex. And of course, IVF is an option for these individuals. This is not an IVF talk, but just to point out, especially for our residents, women with PCOS are at a particularly high risk for OHSS, ovarian hyperstimulation syndrome. So just to kind of put a key there. And then finally, pregnancy outcomes for my MFMs in the room. So we do see in PCOS patients higher rates of pregnancy complications, GDM, preterm delivery, preeclampsia, no increased risk for pregnancy loss per se, and metformin apparently does not really decrease the prevalence of these outcomes. But this was, and this will be my final kind of like research section, we don't really know what the pregnancy outcomes are different in the PCOS phenotype. So I just published this in the Green Journal last year. So what I wanted to look at was what is the correlation of the PCOS phenotype? So what type of PCOS does this patient have, and what does their pregnancy, what do their neonatal outcomes look like? Again, we think that this hyperandrogen PCOS may have maybe the strongest predictor of kind of negative metabolic dysfunction, and non-hypergenic PCOS, as I've shown you this before, has kind of the more mild piece. And so perhaps looking at patients with distinct phenotypes may allow for better characterization of PCOS and allow us to better guide individualized treatment and pregnancy outcomes for these patients. So my hypothesis was that obviously hyperandrogenic patients have worse pregnancy and neonatal outcomes compared with our non-hypergenic PCOS. So this was a project that I did through a CREST scholarship program, but they basically gave me 2 giant databases. So one from that huge study I just showed you, PPCOS 2, and another one, PPCOS 1, its predecessor, where they were basically looking at which fertility treatments work better for PCOS patients. And so I took all of this data and they followed these patients out through pregnancy. So they know what happened to these babies. And we compared the kind of hyperandrogenic PCOS versus the not. And we looked at clinical pregnancy rate, their loss rate, live birth, complications, neonatal outcomes. And what we were able to see, so there are about 1,200 hyperandrogenic. So that was the majority of the population versus our smaller 127 non-hypergenic PCOS. They were similar in age. They were predominantly white. And so not surprisingly, we saw that the hyperandrogenic patients had a higher BMI and waist circumference. They also had worsened fasting insulin resistance. So this kind of substantiates what we know about hyperandrogenic PCOS. But when we look at actual pregnancy outcomes, so the women with the hyperandrogenic PCOS took longer to conceive. So they had longer periods of infertility, and fewer of them actually achieved pregnancy during either of these fertility trials. So 30% versus 40%, and they were less likely to have a live birth. So 20% versus 33%. So I think this is a signal as well. There are different forms of PCOS, and this just shows it to you graphically. The hyperandrogenic PCOS patients had lower live birth rate as well as lower rates of achieving pregnancy, similar miscarriage rate overall. And then when we're looking at neonatal postpartum outcomes, overall, as you can see, all the p-values are non-significant. They were fairly similar, but I will say asterisk, these are very rare outcomes, right? So we were not powered to look at any of these outcomes truly, but just from a kind of broad base, there did not seem to be any major differences in the neonatal outcomes. And just to mention, I didn't make a slide, no differences in GDM, which I was surprised by, preeclampsia. So what we saw, obviously, had lower rates of pregnancy in the hyperandrogenic group compared to non-hyperandrogenic group, similar miscarriage, pregnancy, neonatal complications. But what this suggests is that perhaps PCOS phenotype plays a role in pregnancy. And then so finally, we will just kind of talk about the long-term health outcomes of PCOS, because I really want to get to our GLP slide, which I'm sure is going to be a question in PCOS. But we do know that 75% of women with PCOS have insulin resistance despite BMI. So even lean PCOS patients can have this. And Lifestyle markers can result in weight loss and improve some of our surrogate markers. We do see that when you do exercise and weight loss, you see decreased androgens, increased SHBG, normalization of the menstrual regularity. And, unfortunately, with our limited time slots, we should spend more time on lifestyle modification than we do. But I do try. My residents hopefully can attest to this. I do talk to them about physical activity versus sedentary behavior. Referring to nutrition, learning how to read labels, cooking food at home, treating the family, especially for my folks who are younger adolescents. So it is first line treatment. These are all kind of asterisks. So calorie restricted diet, these are this is what's said in the international guidelines, but we know that obesity is a disease process. These things, and I've had patients who eat, less than 1,000 calories a day, exercise an hour to 3 hours a day, and are really not seeing any weight loss. And I do think that there is a lot of pathophysiology within PCOS that drives that. Our first line treatment right now is metformin, especially in our individuals with insulin resistance. So this is not a weight loss medication. It is not a fertility drug, but from our patients with impaired glucose tolerance, evidence of insulin resistance, I do use this medication, and this is my regimen. I try to taper them up. So I use extended release metformin, 5 milligrams a day, and I slowly taper them up, once a day, then twice a day, and finally 3 times a day until they can take it in perpetuity, hopefully. So, okay, let's talk about GLP-1s, because I know I'm going to get questions. So we know that GLP-1s are medications that regulate blood sugar and appetite through stimulation of the pancreas to release insulin and suppress the release of glucagon. From a PCOS standpoint, how does this impact androgen? So it can also help to transform that LH insulin state of androgen synthesis to a more FSH-driven follicular development. So that's why I think this is a really interesting medication from a PCOS standpoint. And some of our early studies are showing that PCOS patients on GLP-1s, have decreased androgen levels, insulin resistance, follicle numbers, increased menstrual incidence, SHBG, and then now we're looking at more ovulation IVF pregnancy rates. These are our currently approved indications for GLP-1s. I stole this slide from my co-fellow who is boarded in obesity. She's giving a talk in February, so we invited her. So PCOS is not one of them right now. We will see what happens with the landscape, but I think, don't look at this, but basically I just want to kind of give you a sample of the studies that have come out so far on GLP-1s. Again, I stole this from Samantha Schoen, my co-fellow, but the greens are showing, obviously we're seeing higher rates of weight loss, lowered BMI, and these are PCOS patients. This is for exenatide. She has a lot of circles. Liraglutide. So we're also seeing a good, obviously weight loss. We know that it's working for that. We are seeing some changes in our menstrual cycle frequency. Semaglutide. So just know this is kind of just to show you that studies are happening, and who knows what will happen with the indication. But overall, we are seeing that GLP-1s have a significant reduction in our BMI, waist circumference, waist hip ratio, some of our insulin resistance markers, HDL, but side effects, safety in pregnancy. A lot of our women with PCOS are obviously trying to get pregnant right now. It's not currently recommended in patients trying for pregnancy. Some of the animal studies are showing some birth defects, so delayed bone formation, skeletal structural variations, reduced growth. But the largest study of GLP-1 exposure in humans so far, this is reassuring, no difference in incidence of cardiac and congenital malformation. And just so you know, I'm so interested in sort of where this is going. There is a huge push to kind of understand the gut microbiome right now. We do see that there are some dysregulated bugs in the PCOS patients. So we know that this may influence insulin sensitivity and secretion, obesity and inflammatory response. And so this is coming. See, I'm so excited. But anyway, we'll end. So in summary, PCOS has a complex pathophysiology and is truly not well understood. This is an active area of research for me personally. The diagnosis now includes AMH, so please order one with your PCOS labs. The treatment should be individualized to the patient's most concerning symptoms. You want to make sure they're having a cycle at least every 3 months. All diagnosed PCOS patients should undergo metabolic screening. This may impact women from adolescence to menopause. So don't forget the people on the fringes. And delay in diagnosis can cause significant burden. So don't forget PCOS. That is it. There's a little table if you want it.
Thank you so much for a wonderful talk. The floor is open for questions. There's one comment in the chat just saying there's interest in an ovarian drilling.
Yes, Dr. Wong.
Dr. Wong here.
It's a mini question, you, and I can pull your paper, but the question about the hyperandrogenic versus, non-hyperandrogenic and the birth rate difference, among those who got pregnant, did they have the same number of live births, or was the difference?
It was all lower. So we took all the patients that did get pregnant and it was still lower for live birth rate for the hyperandrogen. So I do think there's some pathophysiology that makes these two groups different.
Kind of, so I have a question about just metformin use for PCOS patients and then getting pregnant, then some overlap here in our worlds, but
Yes.
any clear recommendations on whether or not to continue metformin or not, if it's really for PCOS once they are pregnant through first trimester, and then based on your talk today also, should we make modifications based on the phenotype or the type of PCOS?
Yeah, excellent.
So I personally clinically, and Dr. Wang can chime in too, I stopped metformin at 9 to 10 weeks, but I just came back from our AE-PCOS meeting where we met with a bunch of individuals from all across the world, and a lot of Scandinavian countries, like in India, they continue the medication all the way through pregnancy and they haven't seen any worsened outcomes, but they haven't seen lower rates of gestational diabetes, which I think is interesting. So I stop it at 9 to 10 weeks is where I'm at right now. But yeah, potentially, we didn't see any major differences in the GDM preeclampsia piece for the hyperandrogenic, non-hyperandrogenic. So I wouldn't start it for that, but yeah, something to definitely think about. But right now I do stop it.
The thing that'd be interesting to think about would be like, you're talking about like transgenerational effect, and if, being on metformin, it may not help the immediate pregnancy outcomes for like GDM, but is there a transgenerational effect for the offspring or children in potentially changing their epigenetic changes and reducing future PCOS predisposition?
Yeah, so
This final piece, I actually, after I came back from this meeting, they picked apart that paper. I am really interested. So if anyone who wants to do this with me, we have all of PCOS 2 has now been out for a decade. PCOS 1 has been out for almost 20 years. So now we have all these babies of women who conceived in these trials. So we can look at this. Some of them were on metformin. A lot of these women themselves are now menopausal. So we can really look at the full spectrum of, even who were all there. So we have access to all this information. So exciting, right? World of PCOS.
The rest of the day. We joined online.
It's going downstairs.
Yes.
yeah.